A big welcome to all the participants to this symposium. This is the IACAPAP Symposium for Allied Professionals. It is one of many to come. This symposium came about following the understanding that we needed to do something that catered specifically to the needs of allied professionals from the IACAPAP. And this will be the first of its kind, and we're hoping that there will be many others. The topic for today's symposium is the multidisciplinary team in child and adolescent mental health, the then and the now. You will hear a bit more about the topic and the speakers in a minute. My name is Yewande Oshodi. I'm an associate professor of psychiatry of the Department of Psychiatry of the University of Lagos, Nigeria. I am also the current IACAPAP Secretary General. And I'm pleased on behalf of the Bureau to welcome every participant that has registered to partake in this symposium, and also to welcome our guests, our speakers, our chairperson. And I'm going to go right ahead without much ado and invite our chairperson. I will start by introducing her. Our chairperson is Dr. Suzie Dean. She is a consulting clinical psychologist and psychotherapist, a director at Stewart Consultancies, an adjunct clinical associate professor of psychiatry of the Monash University in Melbourne, Australia. Dr. Dean has also had the privilege of serving as an executive member of the IACAPAP for 8 years, and has also represented the Oceania region of the world in the IACAPAP. Join me in welcoming Dr. Suzie Dean. You're welcome, Dr. Suzie.
Thank you so much, Yewande. It's a pleasure to be here. And welcome to everybody to this webinar coming to you from Melbourne in the state of Victoria, Australia, organised by IACAPAP in concert with Mental Health for the Young and Their Families Victoria, a multidisciplinary and community advocacy group here. To begin, in Australian custom, I acknowledge the First Nations people on whose lands we, your presenters, live and work. We honour their elders, past, present, and emerging, and we know that sovereignty of this land has not been ceded by them. We are greatly indebted to these custodians who countenance our presence and work here. You, our symposium participants today, are from 70 countries, over 70 countries, all continents, a wide range of societies and cultures, and we welcome each one of you. Our esteemed speakers today represent several professions working in child and adolescent mental health in Australia, the disciplines of clinical psychology, social work, speech pathology, occupational therapy, family therapy, and psychoanalytic psychotherapy. Two are also trained teachers. Beginning with the inception and growth of mental health services for for youth and children in the Western world, we will explore how the varying professions can work in psychiatrists to benefit the young and their families. Reviewing multidisciplinary work here in Australia, it may open our thinking to issues facing colleagues in other countries too. Jim Grimwade will speak for 30 minutes on how the history of CAMS came to involve a range of specialist professions and how collaboration has evolved, followed by our panelists, Ruth, Wraith, Diane Jacobs, and Anne Jeffs. Each panelist, once introduced by me, will respond in turn to Joe's presentation. They will then all together discuss critical points. After this, I invite everyone attending to respond to issues raised. We'll have a good 20 minutes Q&A after that. To commence, I want to introduce you to Joe Grimwade. Professor John Grimwade has worked as a clinical psychologist in child and adolescent mental health for over 40 years, as a clinical family therapist for 35 of those. He has encompassed practice in government clinics in 3 states and in Central Australia, and in non-government services, government services in private practice. He's also held key teaching positions within 3 postgraduate clinical psychology programs, the last as professor and head of clinical services at Melbourne's Care Miller Institute. For the past 15 years, he's been president of Mental Health for the Young and Their Families Victorian Group, heading up advocacy. This wide experience across urban, rural, remote, public and private settings has connected Joe with many groups, including Aboriginal and new immigrant communities. He's worked as a lone clinician and with multidisciplinary teams, exploring a range of collaborative models. And because of this, coupled with his true scholarship in child, adolescent and family mental health, Joe can share with us a deep understanding of the history and creative potential of our field. Joe, please begin.
Hello, everybody, and welcome to all those from all over the world. It is a great privilege to be able to join with you. I'm trying to get online with my slides, and the moment I think you can see my little private practice zone in my house as I come online. This is a view into my world, which is my world, which I work in as I just trying to make sure the screen comes up. Screen sharing, and I too would like to acknowledge the lands of the people on which this work was created, the Wurundjeri people of the Kulin Nation, but I also spend time on the lands of the Wadawurrung people when I go to the beach, to my beach house. I am been doing this for a while, and this is a result of work that was part of my PhD thesis on the intake to the intake and referral process to CAMHS. And my idea was that somehow the way we begin our work is always affecting the outcome. And if we don't actually attend properly to how we begin, we don't actually arrive necessarily at a place that is satisfying. And although that might sound a long way from this historical document that I'm about to present, the way CAMHS, the way child psychiatry came into being is also very formative, very informative of what we do in our practice. And it started with a multidisciplinary team about 1906. And this is the structure of what I'm going to be talking about. I'll be going through, basically this is a historical presentation, but the point of the historical presentation is to have anybody anywhere in the world understand how child mental health comes into being. Everybody in IACAPAP needs to know this story, and lots of people don't know any of it. And I have banged on about it a few times in various places, and it's got phases. And the Judge Baker Clinic in Boston is the most important one, which is where I start. But we've had transformations in service delivery. We've had family approaches. We've had, in Victoria, we've moved to generic and interdisciplinary practice, and this has led to the waning of the multidisciplinary team. And and further under resourcing is a problem. But we want to be able to encourage people everywhere to try and build the specialist and diverse group of professionals that can attend to the needs of children from a number of different perspectives. And these perspectives are very important to be joined together, because a child and their family is not just one problem. And unfortunately, we have moved to a state of trying to believe that we fix one problem, we fix them all. No, we strongly believe that we need to, from the start, try and work together to produce a complex, coherent, and collaborative process whereby family issues and child issues and developmental issues are mixed together in a coherent way that produces the best outcome for children with particular dilemmas. You could go back to 1870 in America if you wanted to, for this journey at the beginning, when they started after the Civil War to try and develop social programs for people displaced and disenfranchised by the effect of that terrible war and the subsequent migrations of people from the south to the north to places like Chicago. But really, it starts around 1906 or 1907. 1907 is very important for the history of mental health in the modern world, when Clifford Beers, who was an inmate of an asylum in 1901, his brother had suicided. He went into mental collapse and into an asylum, and he saw in there the most horrific things that could ever happen. We talk about asylums, and that was really bad. And he decided that you needed a mental hygiene approach. That physical hygiene had been very good with overcoming a lot of health problems, and he took a mental hygiene approach and got sought allies in the major psychiatrist, the major Adolf Meyer, the major psychologist William James, and tried to get on side with various political forces. And in 1909, Teddy Roosevelt, the president, convened the first conference on childhood, which is a pretty remarkable achievement to go from launching his mental hygiene program to actually having a national conference on childhood. And this was repeated for several terms of about every 4 years. They would have one of these prior to the First World War. But the conference determined that we needed to know whether adolescent delinquency or criminality was born or socially formed. And to investigate this phenomenon, they had a research program where there was a medical doctor, an educational psychologist, and a social researcher, often a social worker. Social work was one of the few early professions of the mental health world, really starting in 1899. But this was the first multidisciplinary team, and it survived as a model well into the 1950s, certainly in Australia, and with a few more disciplines added as things changed. William Healy released his report in 1915, which is called The Adolescent, and he described the social causes of crime in adolescence. The research has been organised through the Judge Baker Clinic in Boston, and Baker was a very amazing judge in that he was interested to know about the inclinations and preferences and motivations of a child who was in the in the juvenile offending system, and he decided that he'd be better off having a clinic to treat the problems rather than put them straight in some sort of incarceration process. Meanwhile, in Chicago, where there was a big lot of people who were displaced and homeless from the South, various people established programs to house, care for, and to support families and children, especially single mothers, to be able to have a more useful life. And they attracted William Healy and the psychologist Augusta Fox Brunner to establish the Illinois Psychopathic Institute, which was later renamed as the Illinois Juvenile Institute of Juvenile Research in Illinois. And this move from trying to tackle a problem of criminality to trying to tackle a problem of mental health is the most important part of the process. And the psychologist, the psychiatrist, and the social worker would sit down together with and discuss the case, and having done a 1 or 2 day assessment, a whole series of assessments, and discuss what was needed to happen. And this was the first multidisciplinary team. And ultimately, the parents would be invited in, and most often the response was, "Ma'am, move neighborhood," because if the child was no longer in the neighborhood that was causing through connections and friendships and bullying and all sorts of things, that child had a chance to differentiate from a difficult environment to one that was more supportive of growth and education. And so impressed were funders with the success of this approach that the Harkness family, who had this fund called the Commonwealth Fund, the Harkness family were 1/8 of the people who funded the development of the oil fields in Western Pennsylvania. The Rockefellers had half of it. The Harkness family had 1/4 of it, had 1/4 of the other half. And they started funding what were called demonstration projects, which would demonstrate that a multidisciplinary approach to the care of children was the better way to go than to try and lock them up. And originally, there was 7 demonstration projects, plus 1 in Toronto. They funded 1 in Canada and 1 in London. And so these were set up, and they started to have an effect on the children who were coming to the courts. But each of the services were rather different, and I don't really want to describe too much of those differences. But the effort was intended to try and make for a better life for children, and that better life for children involved getting together from different points of view to discuss what was options. And by the end of the 1920s, there were 28 such demonstration clinics. But there was another change, which was the demonstration clinics were able to show that they were more effective in working with what they called neurotic children than with what they called young offenders. And at the same time, there occurred, especially in social work, but in other professions, what was called the Freudian turn. And so child psychotherapy became one of the major interventions with the children. And in fact, many of the staff undertook their own analysis because they realised that they had suffered as well. And we have this Freudian turn across the profession. So let's talk about these changes in service delivery. First, it was asylums to clinics. Then there was from criminality to neurosis. And then there was from mental hygiene to mental health at the end of the 5th decade of the 1900s. After the Second World War, a new metaphor came into place in 1949 with the World Mental Health movement, which sort of took over the mental hygiene idea, and it was much more expansive, whereas mental hygiene was really about trying to tidy up or clean up what was the mess. Mental health was now an aim of an aspiration for a general healthy population. And but in Victoria, for instance, in Australia, the mental health organisation retained the name of mental hygiene into the 1960s. So these changes were sequenced across time in various places. But Victoria had been one of the first places to adopt a child psychiatry clinic in 1928, established by John Williams within the hospital then called the Children's Hospital, and later in 1955 became the Royal Children's Hospital. And at the same time, the professions were changing, and although there was nominally a medical doctor in charge of the team and doing the assessments of the children, child psychiatry really didn't appear until Leo Kanner produced the first edition of Child Psychiatry in 1935, and medicine right across the board was specialising, but so was psychology and social work to a lesser degree. But there was mental health social work courses from the end of the First World War. And this is the process. We've got this continual involvement of interaction across perspectives, but also a development of knowledge and how best to intervene and what to do about children who might have otherwise been lost to the system. Then, with the end of the Second World War, there is a great number of innovations that start to appear. Medications, neurodiversity diagnoses. Kanner and Asperger were producing papers on autism in the 1940s, even while the war was going on. There was brain surgery, and the brain surgery was being developed at Palo Alto in California, now Silicon Valley. At the same time, in the same hospital, which was a naval veterans hospital, they were developing family therapy approaches. And so there was this tension between the physical and the social that was being explored, but always with people from different perspectives. Child-centered psychotherapy became mainstream, along with child-centered parent psychotherapy. The 1950s was a very strong period of development of Freudian approaches, but it was also the period of development of family-based therapies, and the major collaboration at Palo Alto included a ward assistant, a chemist, a psychiatrist, and I can't remember the other one. But again, the idea that different perspectives produce better outcomes when combined, collaborative, coherent, this is the basis for what became child psychiatry, and it's what led to the establishment of the child psychiatry clinic at the Royal Children's Hospital under Winston Rickards in 1955. And 1955 is a very important turning point in the history of child and adolescent mental health, I think, because very soon Winston had got together with a whole pile of people to create this idea that you work together from different perspectives and formed a complex and interesting intervention that tried to deal with the whole family and the whole child rather than just bits and pieces. And Winston was very much involved in several of the conferences on mental health. The 1961 International Conference on Mental Health in Australia was partly his work, but also he was involved with IACAPAP, and he in fact, when he started with that organisation, it was just the International Child Psychiatry Association, and he got the adolescents included, and he got the allied professions included within the name. those who knew him and those who knew him well, like Dr. Suzie and Ruth Wraith will tell you what a wonderful person he was. I was certainly very inspired by him, and he really believed that we need to see the whole child rather than just the bits and pieces child. But along with this process came a wish for various professions to upgrade their skill base and upgrade their capacity to work with children from different perspectives. And inpatient mental health units, but with staff by psychiatric nurses became common. There were family therapists who became common. Occupational therapists were joining, speech therapists were joining to try and make these teams more multidisciplinary. But eventually, the people who got into these jobs started to want to do the really hard stuff of the child psychotherapy in particular, and were very good at it. But you start to have an erosion of the multidisciplinary team from within, and a more specialised view of intervention that starts to erode the multidisciplinary team into an interdisciplinary model, and everybody doing the same thing starts to lower the quality of service delivery because the difference starts to disappear, and the obligation to consult with other professions starts to fall away. And that is a real sadness for me. And a lot of us on the panel will say that we came into it thinking that multidisciplinary work was the thing, and have become increasingly disappointed as this approach has waned in the 1990s. I've already said about the adding of the new disciplines, and one discipline that I haven't actually mentioned so far is the lived experience. And this is an important development. People who have been in mental health services have been asked to join multidisciplinary teams to represent the views of the patient. But in children's services, this is a bit of a problem, because the people who can actually represent lived experience of child participants are usually older, 16 or 17, who have had psychotic episodes, or parents of the children. And this has set up a dual constituency or dual problem, in that some of the professionals are working alongside lived experience advocates, at the same time trying to treat the lived experience person with their particular psychological or psychiatric problems. And this blurs the boundaries, and some people found it very uncomfortable to have both have a client as both a patient as both a colleague and a patient. It was it works in quite well in adult mental health with the most severe people, most severely affected mental health people, but it is not something that works particularly well or without complications in less unwell people and amongst children. So we move towards generic skills, and certain specializations survive, especially with neurodiversity and neuropsychiatry and neuropsychology. But mostly we start to move towards this position where anybody can do anything. Nobody really is looking at what the whole child anymore. Somebody's made an assessment that they need A intervention or B intervention or C intervention, not A, B, and C. And the multidisciplinary work, which was always a test of ideas as well as a collaboration, became viewed as tiresome and inefficient. And I've already talked about lived experience in the MDT, and trying to pretend that patients and colleagues can be of the same level created all sorts of difficulties for some therapists. I don't have any particular problem with it, but I like to let people know when I think they are, when I'm consulting with them as lived experience people, as against when I'm trying to help them overcome their particular dilemmas. And we have, but while the multidisciplinary team has disappeared, there is a surviving remnant of the idea, which is called the care team. The care team is a fairly, well, it's the last 20 years or so, become quite common. But it differs from the multidisciplinary team in a number of ways. Firstly, it is usually all the people involved who may or may not be part of the one service. It could be the GP, general practitioner. It could be the child protection worker. It could be somebody doing carer support who are employed under a different scheme we have in Australia called the National Disability Insurance Scheme. And trying to get all these people working together or even to have a regular meeting can be quite difficult. And the disability service coordinator or child protection manager usually occupies the position of chair. In the original multidisciplinary team, the leader was the chair of the meeting, was the psychiatrist on the case. That softened quite a bit, and as Anne Jeffs will show later, this is not the way her multidisciplinary teams work within her service. But care team meetings often get become a game of avoiding responsibility or shifting responsibility, because the care team wants the therapist to fix the child, and everybody else wants to sit back and not have to do very much work. And this is a real problem. Multidisciplinary team was based on the idea that we share responsibility, we share decision making, and no particular thing is more important than the other. There may be priorities, but we all need to be involved. Whereas care teams can be a shifting of responsibility to particular people at the expense of really supportive, coherent, cooperative work with those others involved. And as I said in the last line there, it's the purpose, difficult for a care team meeting to remain as care rather than a forum for blame. And as we would know in our practice, when we start to move towards a culture of blame rather than culture of responsibility, and that's the core of the multidisciplinary team, we do get into the blame. It's not actually all that very helpful for the children with whom we're working and their families. So I'm asking, having sort of rushed through this decline of the multidisciplinary team from its initial roots, its heyday in the 1950s and 1960s or 1970s when some of us started, and try and bring that back and get the essence working for our clients. Now, I realise that there are many countries in the world where there might only be one speech pathologist and one occupational therapist, and the idea of being able to get together and work on a case from different priorities might be difficult. What I am saying is that at its best, the multidisciplinary team is more likely to meet the needs of families with children with particular mental health needs. We need to recognise priority and urgency. We need to recognise speciality. We need to recognise training and experience. We need to develop our members of our teams to be able to do the more complex roles, while at the same time observing the complementarity of roles and responsibilities to ensure that there is this diversity of input. Diversity is balanced by shared goals and shared timelines. If we don't have a way of thinking about things, that we do this bit and then we do this bit and we work together, etc., we start to fragment again. The chairing of the meeting needs to be shared, and the minute taking needs to be shared. Everybody needs to do the roles of the team in a shared way. It doesn't mean that you lose your disciplinary responsibilities, but where things need to be shared, they need to be shared. There needs to be a calendar, if you like, for multidisciplinary team meetings and care team meetings, such that we know that we are responsible to others, and we know that we have things that we need to try and do before we next meet, and to take those responsibilities and to respect the responsibilities of others. Respect is a very important part of this process, which can be lost when you're working on your own. And there needs to be, we need to organise shared learning opportunities, whether in our service or across services. We need to know what other services are doing to inform our own practice. And it is really useful to have group supervisory sessions to, again, invigorate the idea of collaboration and having treatment coherence. I thank you for your attention. You may like to put some questions in the question and answer box. That is my presentation. My name, my email is available. If people ever want to contact me, I'm quite happy for people to do that, and through the email, and I'll try to respond as soon as I can. Thank you, everybody. I hope the quick run through there of the history of the multidisciplinary team has been understood, and that we are in the position to do.
Thank you so much, Joe. You're elucidating that history and bringing out the important lines of development in our field are so important. We're now to hear our panelists' responses to Joe's presentation. And first, I'd like to introduce Ruth Wraith. Hello, Ruth. After working with adolescent girls and young women in a psychiatric hospital as an occupational therapist, Ruth transferred to the Royal Children's Hospital, Melbourne in 1963 as a child and adolescent psychoanalytic psychotherapist, with further postgraduate training, including a Master of Child Psychoanalytic Psychotherapy. Throughout her long career, Ruth has worked in multidisciplinary child and adolescent mental health, inpatient, outpatient, and community services, spanning clinical work with children and parents and carers, and liaison with, training and mentoring of other professionals, including doctors, psychologists, social workers, teachers, speech pathologists, and nurses in each of those service areas. Ruth pioneered clinical specialty in child and community trauma following natural and human-induced disasters and catastrophes in Australia and in countries around Asia, with extensive collaboration with health and welfare organisations and government departments. Ruth was actually awarded the Order of Australia Medal in recognition of this work. At retirement, Ruth was head child psychotherapist at the Royal Children's Hospital, Melbourne. Among varied professional engagements, she is a past president of the Child Psychoanalytic Psychotherapy Association of Australia, the Australasian Society for Traumatic Stress Studies, and the Royal Children's Hospital, Melbourne alumni. Ruth, please give your response.
Thank you very much for your introduction, Suzie, and welcome to everybody who is with us this evening, or it's this evening in Melbourne, but from where you are. Professor Grimwade has given us much to think about this evening, and I'm going to briefly focus on interdisciplinary teams and multidisciplinary teams from within the Australian public mental health context, where we're fortunate to have many different allied health professions embedded. And also, I'll draw on my international experience in developing countries. In many circumstances, including in Australia, as well as in many developing countries, mental health practitioners need or are required to use their mental health knowledge and their skills within an interdisciplinary team model that is directed towards generic clinical practice. This means the clinician's specialist professional skills are generally not used to address the specific clinical needs of the children referred to them. The interdisciplinary model also eventually leads to the undermining of specialist mental health skills. Multidisciplinary mental health teams are comprised of clearly identified mental health disciplines who work within their professional knowledge and skills to meet the specific clinical needs of each child as an individual within their family and their social context. The team works collaboratively within a communicative, coordinated structure to contribute to assessment, leading to treatment that is tailored to the diagnosis and the needs within the child and family. Therefore, the appropriate disciplines manage and treat the identified issues. Multidisciplinary teams are able to provide in-depth, holistic, and nuanced assessment, treatment, and management as required. In pediatric physical medicine settings, multidisciplinary teams have long been in place. For example, the Complex Care Hub for Chronic Conditions at the Royal Children's Hospital in Melbourne. But we have not got that long tradition for mental health. For decades, I was fortunate to work in a multidisciplinary team environment, and I came to know and understand what best practice is about in child mental health. My role as a child psychoanalytic psychotherapist was to work to understand the inner world of the child's fears, wishes, attachments, how they understood and made sense of their lives and the world that they lived in, and how the child strove to live and engage with life and with their outer world. In later years, I sadly worked in the unravelling of this vibrant, clinical, effective service to the point of witnessing and experiencing a type and standard of clinical care that would not be tolerated by clinicians or the community in physical health settings. And this was the move to generic interdisciplinary care as standard practice. The change occurred in circumstances where specialist skills were readily available. While interdisciplinary teams frequently have a role in mental health wellness services, especially where resources are limited, a seismic change is needed in more resourced environments to reinstate nuanced and professionally skilled understanding, management, and treatment by multidisciplinary teams, at secondary, I'll repeat that sentence, if you'll forgive me. While interdisciplinary teams frequently have a role in mental health wellness services, especially where resources are limited, a seismic change is needed in more resourced environments to reinstate nuanced and professionally skilled understanding, management and treatment by multidisciplinary teams as secondary and tertiary level services for children with emerging or complex mental health conditions. Fortunately, there is hope for an improved future of mental health care of a high standard for children. I believe and have experienced that from small beginnings, big things can grow. And our next panelists will explore this further. Thank you very much. Bye for now.
Thank you. Thank you, Ruth. Thank you very much. You really highlighted there some of the big advantages that Jo was also pointing to, and the many important challenges that we're facing here in Australia and I suspect elsewhere in the world as well. Thank you for that. I now turn to Associate Professor Diane Jacobs to respond further. Diane Jacobs. Diane has been a speech pathologist for over 30 years. After working initially in government and private practice educational settings, Diane moved to CAMHS, employed as both a speech pathologist in a couple of hospitals and as a case manager at the Royal Children's Hospital that's been mentioned earlier. Completing masters and then PhD qualifications in psychology in 2009, she transferred to the Helping Children with Autism team at the Scope service as a psychologist. For the past 15 years, Diane has been a speech pathology academic, the last 10 at the Australian Catholic University, now as Associate Professor. In this position, she has had the opportunity to teach undergraduate and master's speech pathology students in Vietnam. It's been online work to assist with the establishment of the speech pathology profession through the Trin Foundation, and has also engaged in interprofessional student experiences in Chile. Diane is a Speech Pathology Australia accreditor, undertaking accreditation of speech pathology university programs. And outside of work, on a more personal note, Diane has been the president of her local kindergarten in 2022 to 23 and is currently a Joey Scout leader, a very important thing in Australia and I think in a lot of other countries too. Thank you, Diane. Please begin.
No worries. Thank you, Suzie, and thanks to Jo for his presentation and for Ruth's lovely response there. So my response to Jo's presentation reflects my experience in CAMHS plus an understanding of how speech pathologists are currently supporting the multidisciplinary team. So I commenced in a discipline-specific CAMHS role in 2003 following the expansion of allied health into the Royal Children's Hospital CAMHS community teams. Before this, most major health networks had a single speech pathologist. So the role involved undertaking structural language and social communication assessments. Case managers utilised this information to inform diagnosis, and it provided case managers with information on the required language level for therapy. So ideally, therapy was targeted at a level accessible to the client, which potentially may not have otherwise occurred. Another identified strength I can see of the multidisciplinary team came from prior employment in the Department of Education local to one of the CAMHS teams that I joined. The familiarity of clients attending CAMHS was quite surprising to me, And in the school setting, though, work was generally siloed. So referral to and from psychology, from assessments to apply for additional school supports. There were no shared discussions around direct student support, and this only occurred within the CAMS setting. Also, after a few years in CAMS, I became a case manager. So speech paths are employed in case management roles, and some of them undertake a one-year developmental psychiatry course. Many clients seen had a differential diagnosis query between autism and oppositional defiant disorder, referred by schools for behaviour concerns, with schools misunderstanding autistic traits. And community teams also established their own autism assessment teams in the time that I was there. And I was able to join those as well. And that was due to the high number of children with autism presenting in the later primary and the early secondary school years. So without that CAMS multidisciplinary team, I think most of these children would have actually been misdiagnosed, and most of them would have ended up with that oppositional defiant disorder diagnosis. My role when working at Royal Children's Hospital was predominantly assessment. However, I later undertook a 12-month role at the Alfred CAMS, and here speech pathologists were employed more days a week, and they regularly provided short-term intervention, especially around social communication. And this showed me the impact that increased speech pathology time in the multidisciplinary team has, and by allowing, additional key skill development rather than just undertaking assessment. Looking at the current landscape, and thanks to Amy Walkley at RCH for this update, following recent government inquiries, most metropolitan services have increased speech pathology allocation into the multidisciplinary teams in CAMS, including a senior educational role. Services are also employing speech pathologists in introductory roles and supporting career development. The model of care includes assessment and intervention aimed at reducing the overall episodes of care, with feedback to services that are supporting children in their everyday environments. And most speech pathologists are still in these discipline-specific roles. But I think speech pathology is a key member of the multidisciplinary team, as over 80% of children with social, emotional and behavioural disorders have a co-occurring and previously unidentified language difficulty. And this is the case with CAMS. A lot of the children coming through CAMS who are referred to speech pathology, they may not have had a speech pathology assessment. While some of them were familiar to me, I'd known them as having seen the psychologist, but not necessarily myself. We know that 1 in 4 children in first year of school has a developmental language disorder, and that 50% of those go on to have a diagnosis of dyslexia, and all will have problems with reading comprehension. So CAMS is the place where we can start to tease apart the presentation and the support needs of these children. Additionally, 8.3% of Australian children aged 5 to 14 years have autism, experiencing challenges with their social communication, with some also have a co-occurring language disorder, hence speech pathology input is required. So I also think finally the multidisciplinary team must include OT. 5 to 6% of school-aged children have developmental coordination disorder, where motor coordination significantly impacts daily living, and I can clearly identify CAMS clients whose DCD diagnosis I missed, but potentially may have been identified by having the OT consistently on the team. In conclusion, I think that children with neurodevelopmental conditions account for many of the referrals to CAMS, and as such, the multidisciplinary team is mandatory, and the multidisciplinary team in CAMS must be valued. And finally, I just had a query to kind of throw out to everyone listening is, how do we implement the multidisciplinary team in rural and remote areas or countries where speech pathology and allied health care is scarce? What's the plan for this? Do we do telehealth multidisciplinary teams? Do we fly in, fly out multidisciplinary teams? Do we do in-country training like happened with the setting up of the establishment of speech pathology in Vietnam through the Trin Foundation? Or is there another solution to how we can actually provide supports internationally? And I look forward to people engaging in discussion about some potential solutions for that. So thank you.
Thank you. Thank you very, very much, Diane, and for your your insights from your perspective and for those questions at the end, very important and yes, very thoughtful. Our final panelist tonight is Anne Jeffs, originally trained as a primary school teacher and worked in inner city schools, including as an English as a second language teacher with Iraqi war refugees in the early 1990s. She then moved to the Austin Repatriation Mental Health Service, promoting reflective practice amongst multidisciplinary teams and instigating processes for including consumer and carer perspectives into service delivery. These experiences prompted reflection upon how the life experience and social context within which a person becomes a mental health consumer can be obscured, can become obscured, and upon the potential of this diminishing effect can have on that person. After training then as a social worker, Anne went on to further training as a child and adult psychoanalytic psychotherapist and brought these roles to experience in multidisciplinary teams in both inpatient and outpatient child and adolescent mental health services. Further, she has conducted private consultancy facilitating reflective practice and supervisory spaces with multidisciplinary teams embracing nurses, social workers, infant mental health clinicians, early years educators, psychologists, and child and perinatal psychiatrists, as well as maintaining a small private psychotherapy practice, and currently works as a clinical educator within the Royal Children's Hospital Children's Health and Wellbeing Service in Western Melbourne, set up recently, where there is a central tenet that teams and practitioners actively involve, value and respect all types of expertise, including lived experience expertise across all functions and levels of the system. And please respond to Jo's presentation.
Thank you, Susie, for that introduction, and hello everyone. I'm really pleased to be here today. I'm going to respond to Jo's presentation by focusing particularly on my current work at the Royal Children's Hospital, which is through the Children's Health and Wellbeing Local. The local locates children's mental health and paediatric services within a community health service. Infants, children and families with a range of presenting issues are referred into the service and prioritised according to a range of vulnerability factors, such as First Nations status, refugee background, exposure to adverse childhood events, and child protection involvement. Usually, clients enter our service through an initial family meeting, which I'll refer to from now on as an IFM. The IFM is a 2-hour initial meeting in the clinic or in the home by 2 clinicians from a range of professional backgrounds. The clinicians are allocated to a particular IFM based on anticipated needs. For example, if parental mental health is a factor, a senior mental health clinician would be allocated, possibly pairing with an occupational therapist or a family support worker. On another occasion, where developmental delay is the presenting issue, it may be a speech therapist and a child psychotherapist pair to do the IFM. The 2 clinicians then feed back their initial assessment and impressions to a multidisciplinary team case conference. All members of our team are encouraged to contribute, explore, disagree, and advocate about the presented family. And subsequent to this discussion, a decision is reached as to how to proceed and which disciplines to involve. Further specialist assessment may be recommended prior to treatment or intervention. The case conference is held twice weekly, with all local team members attending at least one on a weekly basis. Up to 20 of the local's clinicians might be present at any one case conference. The disciplines represented From the mental health team are child psychiatry, paediatrics, mental health clinicians from a variety of backgrounds, including nursing, clinical social work, clinical psychology, development, mental and educational psychology, family therapy, infant mental health, and child-parent psychotherapy. Disciplines from the community health include speech therapy, cultural workers, a paediatric dietitian, occupational therapy, lived experience practitioners, service navigation workers, wellbeing workers, and family support. A family will often be involved with several disciplines over an episode of care. There is a clear focus in case conferences on the family's goals, as well as the child's need. We sometimes end up providing a much truncated version of what we might ideally want to offer due to parental capacity and perspective. Team members bring cases back to the case conference periodically for fresh input and to discuss treatment outcome and discharge. One of the aims of the case conference is to ensure ongoing exposure to different discipline perspectives and to build capacity and knowledge about the unique perspectives and experience of the various disciplines. It is anticipated that as the service develops, clinicians will develop skills by exposure to other disciplines that will enhance their clinical capacity, but also to be able to more quickly identify when there is a need for specialist intervention from another discipline and make prompt and appropriate referrals. And I might just leave it there. There's lots more I could say about the local, but perhaps it will come up in the panel discussion. Thank you.
Thank you very much, Anne. Yes, there is plenty to discuss, and we're going to proceed now to have all of the panelists and Joe back on the screen together, and we will proceed to a joint discussion. Some of those points that that Anne was just alluding to could be expanded on, but I'm going to hand it over to you now to talk. We'll have about 10 minutes for this, folks. Anne, would you like to say something more about the care team meetings, perhaps?
Yes, thanks, Suzie. So one of the factors that we have in Victoria, perhaps unique to Victoria or Australia, is in the outside of the local, in the service system around us is a system called the National Disability Insurance Scheme, and it funds early intervention for 0 to 6-year-olds, 0 to 7-year-olds, I think. And then also if somebody has a diagnosis from 7 upwards, there will be an intervention. It's often around neurodevelopmental needs, ADHD, autism. And one of the challenges that we have at the local is that when we're trying to work with people, with families that are involved with the NDIS system and with the local, there's often a clash of perspectives because our multidisciplinary team has such a complex and thoughtful process. We're often able to think of families within, for example, family dynamics, intergenerational history, the social context from which the family emerged. But in the private practice, in the private service, which is the NDIS, end up providing funds for private practitioners. Often those private practitioners have not got the opportunity to think in that way. So when we have a care team meeting, it's often led by a coordinator from the NDIS who may not have the type of perspective we have. So the role of, who's got the authority, how do you influence in a respectful way, but how do you move to a more complex way of thinking is a real issue. I don't know whether others have any experience of that or perspective on it. Perhaps you, Di.
Have perspective on that.
Yes, you're raising the question there of collaboration between services and how it is that our multidisciplinary collaboration can extend beyond services, how it can be more integrated across society in a way, isn't it? Which brings us, I think, to some of the questions that Diane was asking too, about how it is in over a whole country things can happen. You were asking Diane about remote situations and so on. I wonder if others might have. I know Ruth has had experience in some Asian countries, and Joe in Central Australia. How can we think about this kind of collaboration across a sector? Ruth, would you like to explain your experience in the disaster area?
Yes, well, certainly I did a lot of work in Indonesia for many years after the tsunami, at the invitation of one of the universities in Indonesia. And what I found was in the professional community and the wider community, there was a great sensitivity to the distress people were experiencing and the needs that people were experiencing. And while mental health services in communities were not established, I started from the premise of starting where your client, your community, your professional community is at. And that basis was that the wider community and the professional community wanted some understanding and some skills development to be able to help the impacted communities in their very, very deep distress. So it was from that basis that I started to work with my team, and it was then that from that basis that the team started to work with their communities. I didn't actually work with the communities. And so the impact of the teams in the communities began to be appreciated and understood and valued by the wider professional community, teachers, doctors, infant welfare centre services. And so very slowly, the awareness of mental health, the desire for further training, and the desire for professional development grew. It took a number of years, so we couldn't look for the quick fix. And the people I was working with realised that they needed to educate the health departments, the wider government, in terms of providing services and funding and supporting the training of staff in universities and institutions. So it was important to actually start where the community, the professional and the individual community were at, and grow with them. And here we are 20 years later, and I'm absolutely delighted to say this is now owned by the university, which is now, and the community is consulting to the government, has a big department providing training, and it is all coming from the local community. I don't know if this is actually answering the question, but I'm describing the experience I had in that particular situation.
Yes, no. Well, it's certainly the input of lived experience is one of the big elements there, and something that Anne has drawn attention to and that Joe was speaking of also. Joe, did you want to say something about this? You'll have to unmute yourself.
I'm sorry, I was just answering another question, there's a whole pile of interesting people putting forward very diverse questions. And
You're looking at the Q&A already.
yeah,
Yes.
but it's, I'm trying to distribute the various questions and through the chat, but thank you everybody for listening closely and asking such thoughtful and intelligent questions. And certainly there's some specific ones that Ruth and Diane need to mention. But I think lived experience is vital to get that, if only because the professionals can be a bit remote and a bit removed from the impact of what they do. We really need to listen to how we affect other people rather than we direct other people to improve or whatever. Now, I know that most people don't direct people to improve in various ways, but the consumer's point of view is that they are being directed all the time. And that lack of power is often perceived as something like professional arrogance. And this is very unhelpful to delivery of a compassionate service. And in the end, we have to remember that we are providing care, not direction. We would like to be able to help people to do things in the most efficient way, but sometimes the troubles in actually addressing the obstacles in the way of getting good service mean that people feel excluded by the process. And that's where the capacity to engage with lived experience people is very important. But nonetheless, it's very difficult to find legitimate and thoughtful and insightful people to give us feedback about lived experience from the point of view of the child. We have to really rely on parents. We can't really rely on the children to give us this process, other than being curious with the people, the children who come to us, and actually trying to work out how the systems that are impacting them are actually affecting them. And we can leave this bit out if we're not actually accountable to our colleagues. When colleagues can say, actually, I think this is probably happening and this is probably happening in the multidisciplinary team, we can cover for our any perception of arrogance and directional intention. I know we don't want to do it, but we would like to do it sometimes. And parents in particular don't like such arrogance in their face. I'd like to also add to the response that there was a woman from Brazil who is now in the Netherlands called Alice, who talked about the problem of funding. This is a real question, and it's a question that even in a relatively well-resourced mental health services as exist in Victoria, Australia, it is a real problem because efficiency says that one person doing one job is enough. We know that one person doing one job is only part of the answer. We need to make sure that we advocate for a range of participation, because that is the best way to address all problems. If you can't actually, as Diane pointed out, if you can't actually deal with the language and speech problems, you're going to have a lot of trouble with the emotional ones as well. And you're going to have a lot of trouble with the capacity of the child to develop through schooling and education. That's the purpose of multidisciplinary work, is to address the various obstacles that get in the way of achieving a good outcome. Now, there is a cost for the multidisciplinary team, but the problem is
Thank you, Joe. Thank you, Joe. I'm wondering whether Diane might like to say something more about any experience she has had of sort of observing or being involved with or promoting or whatever speech pathology in outreach, in more attenuated situations where you may not be able to actually be in the room with somebody.
Well, I think probably like most services, we've moved into telehealth and providing telehealth provision. I mean, I think that's happening in potentially, I don't know if it's happening in CAMS, but it's definitely been happening in private practice for quite a while, pretty much since COVID. That is the way that rural and remote have been able to access services. If we think about funding, I think if you look at the TRIN model, which was assisting with the setup of speech pathology in Vietnam, that was run on a shoestring. Initially, it was private people getting donations to assist and then getting funding of one person through the Australian Volunteers Foundation for a number of years. It snowballed, and I think a few years ago after that, they got from USAID $1 million to assist with running programs. So they started really small grassroots with little amount of funding, snowballed, demonstrated the need and the success of it, and then applied for very large grants to be able to roll out the discipline in that study. So potentially you could think about something similar with regards to CAMS, because I think we saw it in Joe's talk about the history. Once you know, demonstrating the strength and the need for the team is really your evidence. It's the outputs and the successful with people having better, more fulfilling lives as a result of coming through CAMS. That is actually your proof.
Has anybody
Diane,
had any
your question's
experience
there.
of working with the multidisciplinary team? With the multidisciplinary team in that way also, not just from the practitioner and the client or patient point of view, but between people. Have you experienced any of that where you are at the moment, Anne? You'll need to unmute.
Suzie, can you just ask me again?
I was wondering whether you have had any experience of telehealth amongst the team at your current work, whether the collaboration can be handled that way, as well as the work with the individual client or patient.
Yeah, actually, Suzie, it does actually happen, because even just for the simple matter that we have a hybrid system of working, so people are able to work for maybe a day or two at home. So that means that even at the case conferences, you'll have maybe 6 people online, and the rest will be in the group in person. And we're getting better at being able to find ways to make sure that we are cohesive in that work. I think it's often hybrid's harder than either all not online or all online.
It's a different mode of working, isn't it?
It really is. It really is.
Yes, good.
Yeah.
Very good. Look, people, our Q&A session has started anyway. So let's say now we'd like people to bring in questions through the Q&A. You just need to type them in there, and they will come up and be seen here. And different members of the team may be able to look at these here. There's an interesting one come here from someone anonymously. I am a clinical psychologist in Asia and have studied psychoanalysis. Next year, I and 2 educational psychologists will conduct research at a deaf speaking school, and together with educational psychology researchers attempt to support the children. I intend to use art therapy for this support. If you have any advice, I would be grateful. It sounds like a very, very exciting and innovative approach to a whole lot of problems, actually. Would somebody else like to comment on that as well? Yes, Anne, please speak.
Yes, it sounds like a wonderful and very
Unmute
interesting.
yourself first.
Sorry, I think I am unmuted. Am I?
Yes, you're right. Go on.
I think it does sound like a really interesting and innovative project. I suppose one of the things I would advise is to get interested teachers involved and to have perhaps a process of reflective practice, because they will know so much more than they think that they know about what might be happening for the children. They often perhaps don't get the time to reflect and to speak about it. So I think, and that's where the true collaboration can come in. Often disciplines that might not be trained in psychoanalysis, for example, they often do see and pick up things if they're allowed to, if they're encouraged to think and to talk. That would be my advice.
Yes, that sounds like a very good idea. Yes, Joe, I think you were next.
Well, look, I just say that one of the most important processes in this work, and it didn't really bring it out, it sort of adds a layer, but when you're doing such a program as art therapy, supervision is really very important. And you know, supervision is, if it's done well, just makes such a difference. And your supervisor usually has a broad basis of experience. And even if the supervisor doesn't, and I encourage everybody who's even a beginning psychologist, this is what I was asked to do as a beginning psychologist, was to supervise others. And I learned a lot about clinical work by trying to supervise people, and I was incompetent. But the relationship that's developed between the supervisee and the supervisor lends the opportunity for learning both ways. And without supervision, you can't really do complex work like is being proposed. Go for it. Wonderful idea. But try and get yourself someone you can trust with your developing skills.
Ruth, you have your hand up too.
Yes, I have 2 points I would like, or 3 points I'd like to comment on and support Joe very much about the importance of good, competent supervision for complex mental health issues. I'd also like to respond about the art therapy request or research.
Yes.
In Melbourne, at a mental health service called the DAX Centre, DAX, many years ago, we developed a program for use within schools through training teachers called Emotional Literacy through Visual Arts. And it was based on developmental and psychoanalytic concepts, with the psychoanalytic concepts presented in an everyday language and framework. And it was designed within a very extensive collaboration with teachers. And the people who are interested in this program might like to Google DAX Centre. I haven't got the website available at the moment, and ask them if they would be able to access the training program. We did have very comprehensive training clinical notes that were very accessible to the teachers. This program was researched evaluated twice by Melbourne University Research Department. So it has a solid base. So that's my response there, which may be helpful for people. Also, a question came in on the Q&A site about occupational therapy, and I answered it on the Q&A site, and it has disappeared. But I'm noticing on the Q&A
It'll be
site,
on the answered section.
it's answered. Wondering if it could come back where it might
If
be
you
more
click on
available.
answered, you can
I
see
think
it.
Diane made a response.
Sorry.
I've got one there on OT. Yeah, which is, it's got the initials MR beside it at 10:02. So I'd just like to be sure that the person who asked the question has received the response. And also there was another question similarly about some ways occupational therapists could advocate for more specialist contributions to policymakers. And I've answered there also in the Q&A box. So I hope that'll be helpful to people.
Thank you very much, Ruth. And thank you too, Diane, for responding to that question. Yes, Joe.
Look, I just wanted to say thank you to the audience for their a range of questions, and it's been a very interesting exercise for me. Who hasn't? But can I just say something more, please? But I am very pleased with the contributions of my other panelists, and I hope that if people want to contact me, they will feel that they can.
One of the things that's come out of this very brief but very powerful segment of our session tonight is that there are issues that we can be sharing around the world, sometimes quite specific issues. And I'm going to see if we can ask IACAPAP to assist in that kind of inter-country communication between the allied professions on some of these issues. There must be a way of going about it, I think, and I'm sure that with their experience, IACAPAP will come up with something useful. If people wanted to share their email addresses on the Q&A, they could do that, and we would have a record of that, and we could get back to them that way. But I'm thinking of something a bit broader. I think that it would be possible to promote the allied professional enterprise in mental health and the multidisciplinary team approach more powerfully through IACAPAP, and we will see if we can achieve something along those lines. So really now the time is drawing to a close, and on behalf of our presenters, I wish to thank everyone participating today, each and every one. Thank you for being our audience, and thank you for expressing your collegiality with the Q&A, and in your collegiality in actually attending to think about collaboration and its benefits. Also wish to thank IACAPAP, of course, for providing this chance, this first chance that the allied professions have had for us to join together across the oceans to express our concern for children and youth really worldwide. With that, I'm going to close and pass over to Yewande, who I know has some IACAPAP messages to pass on. Thank you.
Much. Thank you, thank you, thank you. Thank you so much to our chairperson, Professor Suzie, to our speaker, Dr. Joe, Grimwade, and all the panelists. Thank you so much for the wealth of your experience that you shared with all the participants, and of course to our participants for attending. So I'm just going to quickly round up by just making a few announcements and just highlight a few things. We will have e-certificates that will be given to all the participants of this webinar, but you need to complete the survey that's going to come up at the end. So please just hold on a minute and you'll be able to do that. It's just going to come up at the end of the webinar, after the webinar ends. The other thing is we have an open house webinar coming up later in October on the 16th that is focused on detection of exposure to bullying and other forms of maltreatment. This is one of the webinars that you do not necessarily need to be an IACAPAP member, so you can share it far and wide to anyone that you think would be interested in it. The author of a book, George Strapstein, would be giving us highlights from his book on bullying and sharing experience from his clinical practice of children and adolescents that have come out of bullying experiences. The other thing that may be of interest is the third IACAPAP regional webinar. This webinar is more focused in the Asian region, and so members of IACAPAP that can keep to that time will be welcome to also join. We will be talking on strategies of prevention for suicide reattempts in youth. We have these regional webinars holding in certain regions that are tailored to their time zones, and so people can join it. It is also an open webinar that doesn't require IACAPAP membership. We have the 26th Launch and Learn webinar, which would come up in November, on the 11th of November. This is specific for IACAPAP members. And in this particular webinar, they'll be looking at autism disorder and a multidisciplinary approach, yet again, in assessment and care. So allied professionals, this may be something that may also be of specific interest, amongst other things, for members of the allied professional team.
Oh, yeah.
We do have a call for special interest groups, and currently we have 3 special interest groups that have been set up. And as you go onto the IACAPAP website, you may find registration to join any one of these groups. And of course, if anyone does want to set up another group of interest and you think you can mobilize enough participation for your special interest groups, we welcome applications annually. But these are the current 3 SIGs that are available for people to join. Please check the IACAPAP website. Sue will put it in the chat for those that don't have it, where you can go to the site to join the groups. Lastly, and every 2 years, we have the World Congress of the IACAPAP, that's the International Association of Child and Adolescent Psychiatry and Allied Professions. So the next one is coming up in 2026, and it will be holding in Hamburg, Germany. This is a good time to take a look, submit your abstracts, set up symposia, and begin to plan to attend. And I think we have slightly less than a year, but at least there's still some time. So this Congress is coming up. It is a very useful conference, a melting pot of child and adolescent mental health professionals, and a good place to network and share experiences and learn a lot. So on that note, I want to, on behalf of the IACAPAP Bureau and the Executive Council, say a big thank you once again to our chairperson, our speaker, and our panelists for making this a very successful symposium. Thank you very much. And of course, to our participants. We look forward to having you at the next Allied Professional Symposium. And as Prof. Suzie said, it is the first of many to come. We're hoping we can create that space where allied professionals can actually, really drill deep and focus on allied professional related, interests and help to also grow capacity in that area. Thank you once again. Have a good day. Bye-bye.